in various prestigious meetings, and her areas of interest are, in addition to critical care, particularly nephrology and renal replacement therapy, sepsis and septic shock. Today, diabetic ketoacidosis is a very important topic, and there is none other than Dr. Shilpa to enumerate and elaborate on details of the same. Over to you, Dr. Shilpa.
Thank you, ma'am, for that introduction. I hope I'm audible.
Yes, you are.
Is my screen visible?
Okay. Yeah.
Is my screen visible, ma'am?
Yes, it is.
Yes.
Okay, so the topic for today is an update in the management of diabetic ketoacidosis. So the latest update is the ISPAT 2022 guideline, which came about a couple of days ago. So last week, to be precise. So I'll be including parts of that also in my presentation. The changes that has come up, what change has come up between the 2018 and the 2022 guidelines, those also I will be highlighting. So let's start with the case. So this is a 11-year-old child who came with the chief complaints of 2 days of vomiting and altered sensorium and abdominal pain of 1 day duration. He was taken to a local hospital, and there he was probably found to be in shock, and he was given one Emisset and pantoprazole IV fluids, and he also received 4 bags of normal saline. Okay, and so that's about 2 liters, and then he was shifted to RPS. So just have a close look at this. Think of is this the typical DK case that you see? Okay. So now we go to the pediatric assessment triangle in this child. When this child came to ER, the child was drowsy. There was increased work of breathing, and the circulation was normal. Then when you go to the primary assessment, the airway was clear, breathing, he had tachypnea, air entry was but equal, and saturation was maintained. So always the first point is, when you have a child who presents with a tachypnea, which is either silent, that is tachypnea without without respiratory distress or increased work of breathing, or when you have a child who presents with increased work of breathing and tachypnea, and when you auscultate, the air entry is equal, there are no added sounds, and the saturation is maintained, always think of a metabolic cause. Okay, so that's a very important learning point. When there is tachypnea and there are no chest findings and saturation seems maintained, always rule out a metabolic cause. Then coming to the circulation, he has some tachycardia, his BP seems maintained, central peripheral pulses are good, CFT is 2 seconds, which is again normal. His GCS was 12/15 and his pupils are 3 millimeters, equal reacting to light. And exposure, he was afebrile and his GRBS was checked and is 525. So the most important point here, yeah, so when we examined him more closely, we found a perianal abscess in this child. So this, though I have put it in the primary assessment, this was found a little later when we actually attempted catheterization of this child. That is when we found this perianal abscess. So why is this important? Again, I'll tell you in the coming slides. So seeing this GRBS of 525, we went ahead, did a blood gas. So this was the blood gas. The pH was 6.8, bicarb was only 2. PCO2 of 12, base deficit of -22. Let's see the osmolality of 312 and sodium of 138. Okay, so how do you diagnose DK? So you have some clinical features and you have the biochemical diagnosis. So the biochemical diagnosis is most important. So any child or any child with ketonemia, that is blood ketones more than 3, or ketonuria, moderate or large ketonuria. That is the first criteria. Second is increased blood glucose more than 200 milligram per deciliter. And third is acidemia, that is pH less than 7.3 or a bicarb less than 18. So this is one change that has come now. Earlier it was bicarb less than 15. Now in the latest ISPAT guideline, the bicarb cutoff is changed to 80. Okay. So it is there in the diagnostic criteria is there in the name itself, diabetic ketoacidosis. So you should have increased blood sugar, you should have ketosis, and you should have some acidemia. Okay. Then a word about euglycemic decay. So is it necessary that all these should be fulfilled? So the thing is, it's not always you may not get a high blood glucose always. Like sometimes the child may be vomiting so much that oral intake may be poor. In such cases, the child may have a relatively normal blood sugar but still be in acidosis and ketosis. Okay. Also, if the child has received some fluids and all from outside, the blood glucose may not be very high when it comes to you. So always be on the lookout for ketonemia and acidemia. So don't just go by the sugar values. Okay, you can have a euglycemic decay. And coming to the clinical features, it's very obvious: polyuria, polydipsia, nocturia, enuresis, weight loss. So these are the features of diabetes. Nausea, vomiting. So in DK, nausea, vomiting. So it may be commonly mistaken for gastroenteritis, abdominal pain, which may mimic an acute abdominal condition. Then features of weakness, fusion. Okay. Then evidences of dehydration may be there. So that's tachycardia, then tachypnea, deep sighing, small respiration, and smell of acetone. And always important that you look for any focus of infection, because especially in children, decay may be precipitated by an ongoing infection. Okay, so always be on the lookout for any, or always be on the lookout for any focus of infection. So that is why I said that in this child, okay, so though initially we did not find any focus of infection, when we were about to catheterize this child, we saw that this child had a huge perianal abscess, and it only if you drain that abscess, only if you treat that focus of infection, will you get a control over the decay. So it's very important in that sense. So again, I asked you in the first slide, this child received about 2 liters of normal saline bolus outside. So that is again a point which should make you think that there is some other pathology other than the decay which is going on in this child. So in this child is probably having a septic shock also, which has resulted in this child requiring so much of IV fluids. Okay. So when do you suspect the sepsis in decay? One, if the child has fever or hypothermia, because fever generally is not a symptom of decay. So if the child has fever, definitely suspect sepsis. If the child is in hypotensive shock, we'll come to that why later. If the child has persistent acidosis, so despite your correction, if the acidosis is not getting treated, if the child has lactic acidosis persisting, and if the anion gap is more than 35. So like we, DK is a diabetic ketoacidosis is a high anion gap metabolic acidosis. So that is, anion gap is, you are definitely expecting an anion gap more than 16, but if your anion gap is very high, like more than 35, then again you should think that there is something else which is adding to this acidosis. Okay, so any child who is requiring many boluses with persistent hypotensive shock, anybody who's having a fever, persisting acidosis despite your correction, anion gap more than 35, always suspect sepsis. Okay, why I'm repeatedly saying this is because unless you treat this, you cannot control the decay. Okay, so now coming to the severity classification, this again has a slight modification from the previous criteria. So again, it's classified as mild, moderate, and severe. So mild is depending on the pH and the bicarbonate. So this, depending on the pH, it's very simple. Less than 7.3 is mild, 7.2 is moderate, and 7.1 is severe. So as for bicarbonate, earlier it was less than 15, now it is 18. So anything less than 18 is mild decay, less than 10 is moderate decay, less than 5 bicarbonate is severe decay. Okay. Now coming to what are the risk factors for a child to develop decay. So in a newly diagnosed case, what are the risk factors? If the child is of younger age, if there is delay in the diagnosis of diabetes, low socioeconomic, low prevalence of diabetes. In a child with a known diabetes, so the most important factor is the omission of insulin. So they forget to take insulin, or the parents don't give insulin because of some reason. Then a child who is having a poor diabetic control, then a previous history of DK again is a risk factor. Then any sick child with gastroenteritis, persistent vomiting, all these are risk factors. Okay. Now, briefly about the pathophysiology of DK. So this is a very important slide. So what happens in DK, or why does DK develop? So basically, diabetes means what? There is insulin deficiency. Okay, so there is absolute insulin deficiency, which, and along with that, there is some stress factor which has come, which is like which is an illness or an infection or whatever. Okay, so or there is insufficient insulin intake. So because of this insulin deficiency, there is and the stress factors, there is an increase in the counter-regulatory hormones. So the counter-regulatory hormones are glucagon, catecholamines, cortisols, growth hormones, etc. So because of the increase in the counter-regulatory hormones, we know how the counter-regulatory hormones act. So they will basically increase your, they'll try to increase the glucose level in your body. So what do? They'll decrease the, increase they'll increase glycogenolysis, which will release glucose, increase proteolysis, and decrease protein synthesis. So that will again lead to increase the gluconeogenic substrates, which are channeled to the gluconeogenic pathway. That will again lead to hyperglycemia. And glucose utilization in the peripheral tissues is impaired, again leading to hyperglycemia. Okay, so all these factors will lead to hyperglycemia. So when the glucose goes over the renal threshold, that's about 200, 180 to 200, what happens? The glucose starts appearing in urine. So that is glucosuria. And when glucose comes in urine, what else comes out? It pulls out water also, and along with that, the electrolytes also. That will lead to dehydration. Okay, and that can lead to pre-renal, impaired renal function. Again, these counter-regulatory hormones will also cause lipolysis, which will lead to increased free fatty acid release. They are taken to the liver. In the liver, they are converted to ketones. And these ketones are basically acids, ketoacids. So this will lead to acidosis, ketosis and acidosis. Also, this dehydration and fluid depletion will lead to increased lactates and lactic acidosis. And when dehydration happens, what happens to your osmolality? There, because of decreased fluid intake and dehydration, there will also be hyperosmolality. Okay, so this is basically what happens when because of insulin deficiency and increased counter-regulatory hormones. Okay. So again, when there is loss of water and electrolytes, what is stimulated? Your renin, angiotensin, aldosterone mechanism is stimulated, which will lead to retention of, which will lead to loss of potassium, and that will again add on to the hypokalemia. This is just to give an idea about what the amount of fluid and electrolytes lost in urine in DK. So the average loss of water is about 70 ml per kg. It's like huge. Okay, and sodium potassium about 6 to 5 millimoles per kg is lost in urine. Okay, now this is an important slide about a characteristic feature of DK. So usually, despite the dehydration, the patients in DK generally maintain normal BP. Okay, they may be severely dehydrated, but their BP may be normal. So why so? Because like we said, there is increased counter-regulatory hormones, so increased plasma catecholamines, which can maintain the BP. Plus, there is increased release of ADH in response to the hyperosmolality. So because of the serum hyperosmolality, there will be stimulation of the ADH. That will again increase the BP. So this is one important point that you have to remember about DK. So that is a DK. In DK, though the dehydration is severe, getting a hypotensive shock is not very common. Okay, it is not that it cannot happen, but it's not very common. So that's why again I'm saying, when you are seeing a patient who is requiring a lot of fluid boluses, you should always think of a cause beyond. There is DK plus there is some other cause for it. Okay. Then another characteristic feature about DK is the patient may be coming in severe dehydration. But if you ask the mother how the urine output, she may tell you that last time he voided say 100 ml or lots of urine. Okay, so there will not be decrease. Urine output is always or usually maintained. That is another feature of a. So when you have a shock child coming with a maintained urine output, always think that it could be there could be a DK. Okay. So what are the investigations that you would do in a child with suspected DK. So first thing is glucose, then urine and blood ketones. A word here about urine ketones. Urine ketone can be used for the diagnosis of DK. So if you find ketones in urine, and is ketonuria, it can be used for the diagnostic purpose, but it cannot be used for the resolution, for understanding about the resolution of DK, because the urine urine ketones will continue to be excreted for about 48 hours after your DK is corrected. So for diagnosis, it can be used, but you cannot use it to see if the DK has resolved. Then very important to check all your electrolytes, not just sodium, potassium, but also calcium, and very importantly phosphorus, magnesium, and all that. And also do the corrected calcium, corrected sodium, we'll come to that later. Then the RFT, they're very important to do this, check the serum osmolality and the effective osmolality. Then the blood gas with anion gap and a complete blood count. So one point about complete blood count is that you may, in DK, because of the stress, the CBC may be increased, there may be a polymorphic response, but that doesn't mean that there is infection. It may be just because of the stress. Okay, and cultures as appropriate and HbA1c for the diabetic control. So what about the initial stabilization? Just like in any sick child, it is ABCD based on pulse management. So you start oxygen, put IV lines, take blood samples. So when we talk about IV lines, we usually put 3 IV lines, one for insulin, one for the fluid, and one for sampling, because you need frequent sampling. So you wouldn't want to poke the child repeatedly. So you will prefer to put 3 IV lines. So oxygen, then antibiotics if appropriate. Then what about catheterization? If the child is oriented, conscious, and if he is voiding, then you need not catheterize. But in a child who is drowsy, you might need to catheterize to know the urine output. Central lines are generally not preferred because DK is a prothrombotic state. So we don't prefer to put a central line unless we are so pressed. So how will you monitor a child? So these are the basic investigations that you do at admission. And this is how you stabilize. Next, how do you monitor this child? So what are the things that you have to see? You have to see the hourly vitals, also the hourly neurological status, that is GCS and pupils, extremely important. So the most important or the scariest thing about a severe DK is whether this child will go in for a cerebral edema. Okay, so it is, especially in a severe DK, it's extremely important to look for the neurological status and continuously monitor the neurological status, that is the GCS and sensorium and the pupils of this child. Then hourly GRBS, hourly insulin. So you should know how much insulin is going, fluid is going, and then the other lab results. That is your electrolytes are usually done. The blood gas electrolytes are usually done 2 hourly for the first 6 hours, and then you do it 4th hourly. So this is our monitoring chart, which has all the clinical parameters plus the fluid insulin plus the RBS, sodium, anion gap, and the effective osmolality. So why have we included this effective osmolality in this monitoring chart? Okay, so let's talk about effective osmolality. So I said, when we talk about DK, the most important thing that you want to prevent, or the one of the scariest complication which can increase your mortality is cerebral edema. So especially if in a child with severe DK. So when we talk about cerebral edema, what is the thing that comes to your mind? It is the osmolality. Yes. So if your plasma is hypoosmolar, that is, the osmolality of the plasma decreases, what happens to the brain cell? The fluid will flow from the plasma into the brain cell, right? And that will lead to swelling of the brain cell, which will result in cerebral edema. Okay, so that is what we don't want to happen. So so that's how osmolality is related to cerebral edema. So what is this effective osmolality? So you know the equation of serum osmolality, which is 2 into sodium plus glucose by 18 plus blood urea nitrogen by 3.6. Okay, so effective osmolality does not include urea, it just includes the sodium and glucose. That is urea being an ineffective osmol, that is excluded, and the rest of it is included, that becomes effective osmolality. So what is our goal during treatment is that we have to ensure that the effective osmolality remains stable during treatment. So this value is usually elevated at the time of starting treatment. It may be 320, So you know that the normal serum osmolality is 285 to 295. Okay, so decay is the hyperosmolar state. So your serum osmolality at admission or before the start of treatment may be anywhere between 320 or 350. So what you want to do to that is you want to slowly bring it down. Okay, so there has to be a slow and steady decline in the serum osmolality. When you are seeing that a very rapid decline or even a slow decline to very low levels like 270s, you have to be worried. Okay, so that is suggestive of excess free water. It means that you are giving more free water and there is a risk of cerebral edema. So this concept has to be clear before we go to the management. Okay, so what is effective osmolality? Why we have to monitor effective osmolality? How we will monitor effective osmolality? Okay. So this is just a calculation of here I've given about uncorrected sodium and all. We'll come to that in the uncorrected sodium is the sodium value that you get in decay, in the lab value that you get. Okay. Okay. So this is just an example of calculation of effective osmolality. So now coming to the management. So what are the goals of therapy? So first is correct dehydration. Okay. Then correct the acidosis. Restore blood gas to near normal. Then monitor for the complications and identify and treat any precipitating events. So the first, so basically it can be divided as fluid therapy, insulin therapy, and electrolytes. Okay. So first coming to fluid therapy. So when we talk about fluid therapy, the objectives of fluid therapy are restoration of circulating volume, replacement of sodium in ACF, improvement of glomerular filtration. So the first is in fluid therapy, the first part is the bolus fluid. So if the decay is in shock, if the child is in shock, then you give 20 ml per kg, that is hypotensive shock. Okay, then you give 20 ml per kg as quickly as possible. Okay, this is as per the latest ISPAT guideline. Earlier it used to be not very clear. So now they are very clear. If there is child is in hypotensive shock, 20 ml per kg as early as possible till your perfusion is restored. And this you need not subtract from your calculated deficit fluid. And according to the BISPED BSPED guideline, if a child requires more than 40 ml per kg fluids, then definitely it is time for you to start inotropes also. And again, as I have been telling before, a decay requiring more than expected fluid, always think of addition and added septic shock also. Now, if the decay is just fluid, the child is just fluid depleted but not in shock, then you only give 10 to 20 ml per kg again over 20 to 30 minutes. This is again another change. Earlier, the last guideline said over 1 hour, and now it says you can give it over more rapidly over 20 to 30 minutes. Okay, so that is a bolus fluid. The second part of fluid therapy is deficit correction. So for finding out the deficit correction, you should know how much is the fluid deficit, okay, of this dehydrated child. Now the problem with decay is that clinical assessment of dehydration is not very accurate. So that's why we generally rely on this. That is, according to the ISPAT 2020, if the child has mild decay, you assume the fluid deficit to be 5%. If in moderate decay, you assume it to be 7%, severe decay as 10%. Okay. So this is the latest guideline. Then, depending on based on body water estimation studies, it has been seen that the fluid deficit comes to about 6.5 to 8.5%. Okay, so that's why this in Milwaukee formula, etc., you have this 85 ml per kg. And by practice, our personal practice is to use this formula of 8.5% dehydration for severe decay and 6.5% for mild to moderate decay. Okay. So if you are assuming 8.5% dehydration, it means that it comes to 85 ml per kg of fluid deficit. Okay. Then to this, you have to add the maintenance volume. So first volume, you have to give a bolus. Okay. Second, you have to find out how much the child has already lost. That is your deficit. And that is depending on the whether the child has mild, moderate, or severe decay. You'll assume 5, 7, or 10% dehydration. And then you have to think about the maintenance volume. So maintenance, next you have to add to that the maintenance volume. So maintenance volume, as in all other pediatric cases, we go by the Holiday-Segar formula. And I'm sure all of you who are listening know the Holiday-Segar formula. So the total fluid now that must be administered to this child is your deficit. Okay, so that is what the child has already lost. That is the deficit plus the maintenance minus the bolus. So you've already given a bolus. If the child is in hypotensive shock, then you don't subtract the bolus. Otherwise, you have to subtract the bolus. So deficit plus maintenance minus the bolus is the fluid that the child should receive. And always remember that you can make errors in calculations. So always remember that the fluid generally should not exceed 1.5 to 2 times the maintenance. Okay, so you should be careful. Recheck your calculations again. And according to BISPET 2020, if the child is obese, then we don't take more than the 97 centile weight for fluid calculation. And as a personal practice, we use only 2/3 of the maintenance fluid in all children. In DK also, we follow that. The maintenance fluid, we take only about 2/3 of the maintenance. So I think I'll skip this slide for want of time. It's just an example of the calculation, or we'll come back to it later. So that is a correction. That is the amount of fluid this child requires. Okay. And over how long should you correct it? How long should you give this fluid over? This fluid is usually given over 24 to 48 hours. So it's generally the consensus is 48 hours. So whatever fluid you get here, this you divide by 47. Why 47? Because your bolus is already gone in 1 hour and you have remaining 48 hours, 47 hours out of the 48. So divide this by 47 and you get your ml per hour of fluids. Okay. And what type of fluid? That is again a debate. What is the type of fluid? So is it NS or is it balanced salt solution? Is it NS or is it half NS? So the consensus now is NS or BSS. Both are okay. If you can give balanced salt solution, it can be given, but NS also is acceptable. So the points in favor of balanced salt solution are that there is a risk of AKI because of the hyperchloremia, which can develop with normal saline. But it is not a very proven or highly evidence-based. So NS is also totally acceptable to be given in DK. Okay. Then again, NS or half NS, again that also according to the latest ISPAT guideline, you can give NS or you can give half NS for the replacement. So all these fluid trials, all these fluid recommendations are mainly based on the PECAN trial, PECAN DK fluid trial, which is a large multi-centered fluid trial done in 1,300 children. Okay, and these children were divided into 4 groups, and they received one group received 0.9%, another group received half NS, and one group received rapid, and another group received slow correction of the decay of the fluids. And what they found was neither the rate of administration, that is whether you gave it fast or whether you gave it slow, whether you gave NS or whether you gave half NS, the ultimate neurological outcome did not matter. Okay, so flow, fast, half NS, NS, neurological outcome did not matter. So can we just blindly believe this trial and say, okay, in any DK, you give anything at any rate, is it okay? So this particular article from Archives of Diseases of Childhood is an excellent article which analyzes this trial. And one important thing about this trial is that they have not included children with a GCS below 11. That is one. And second is that about 90% of their children had GCS over 14. Okay, so there were very few children who actually had a poor sensorium or were drowsy who are included in this trial. So I would be very reluctant to use this formula, that is as fast any fluid in a child who is severely drowsy, in a child who has severe decay. Okay, also it is a 2x2 factorial design, which is quite a complex design. That is another flaw of this trial. And the actual fluid received also is quite erratic. If you look at the supplements of this, which is published in NEJ, okay, so, which is not published with the main article. So, so in short, what I mean to say is that though these are the guidelines, these are what the guidelines recommend, that is NS versus half NS or slow or fast. What we should remember is that we should go according to the condition of the child. So if you have a child who is severely drowsy, who is has a severe decay, very low CO2 representation, who has a very high risk of cerebral edema, I would definitely not start half NS in this child. I would definitely go for NS only, because I don't want the osmolality to fall very rapidly. I want a slow correction in this child. So I would go for a slow correction and not a rapid correction, and I would go for NS and not half NS in this child. Okay, so go by your patient. So we have started the fluid. You know how much to start, at how many ml per hour to start, we know. Next, when do we add dextrose? So we expect the glucose to fall about 50 to 100 milligram per deciliter per hour, every hour to fall about 50 to 100. So when the dextrose falls by to about 250, then you add 5% dextrose. So if you're giving DNS, you change it to DNS at that point. Okay, can a child on decay correction take oral fluids? So generally, this child is sick, child has vomiting, child has gastroparesis. So we prefer not to give oral fluids till the child is better, decay is corrected. Okay, and if at all you're giving, it has to be subtracted from your volume. Okay, potassium. So potassium is a very, very important electrolyte in decay. Why? So hypokalemia is the norm in decay. Why? Because once we said, because of polyuria, along with your water, potassium also goes out. Then now the next thing we said is because of hyperaldosteronism, again potassium loss occurs. Then if your child is malnourished, it's an add-on risk factor. Okay, so what does insulin do to potassium? Insulin will drive the potassium inside. You remember, insulin is a treatment of hyperkalemia. Okay, so insulin will drive your potassium inside the cell, which means once you start insulin, your potassium is going to drop further. That is one point. Second, acidosis. Okay, so what does acidosis do to potassium? Acidosis will bring out the potassium from the cells. Okay, so acidosis will. So the thing that you have to remember is that if a child with decay has a normal potassium, say the potassium of the child is the pH of the child is 6.8 and the potassium is 4.2. Okay, so it is a normal potassium, but this normal potassium is in the presence of this severe acidosis, which means when you're correcting the acidosis, as your decay gets corrected, acidosis gets corrected, this as your pH goes up, this potassium is definitely going to fall. Okay, so these are the things that you have to remember. So as your acidosis gets corrected, your potassium is going to fall. And as you start insulin, potassium is going to fall. So always remember, it's very important to keep a track of potassium in decay and to correct appropriately. Okay, so the initial levels can be low, normal, or even high sometimes. Okay, so what do you do if your potassium levels are normal initially? You have to add double maintenance potassium. Usually the normal maintenance potassium is 20 milliequivalents per liter. So if you have a normal potassium, we add double maintenance of potassium to your maintenance fluid. So maintenance fluid is the one which we mentioned earlier, that you get the deficit plus maintenance minus bolus divided by 47. So supposing if you're getting 70 ml per hour, so to that you have to add 40 ml per liter of potassium. Now, what if you are getting a high potassium value at admission, 5.5 or 5.7? What do you do then? Again, we know that this high value is in the presence of this severe acidosis, but we wouldn't add potassium till you have got a urine output. You have to first make sure that there is no AKI which is causing this hyperkalemia. There is no AKI once the urine is passed, and once after you give fluids, once the potassium, the acidosis gets corrected, this potassium will again come down. Then you start potassium for this child. Okay, what if the patient has hypokalemia at presentation? Now this is a very dangerous situation. Already it is only 3 or less than 3. Now it is going to fall further. So then you remember that in your bolus fluid itself, so you have to add 20 milliequivalents per liter of potassium. And till your potassium is at least about 3, you don't start insulin. Start insulin only after your potassium reaches over 3. Otherwise, the patient can go into severe hypokalemia and even have arrhythmias or arrest. Okay, so this was a question. I don't think I will ask that now for want of time. Okay, so if there is a patient at admission has potassium of 2.5, how do you treat it? First thing that you do is add potassium in your bolus fluid itself, in the 10 ml per kg potassium, followed by potassium in your maintenance fluid, and you start insulin only after your potassium is more than 3. Okay, so that is about fluid therapy. Now we go to, so fluid and potassium goes together, so that's why I said that together. Next we come to insulin therapy. Okay, So what's the dose of insulin that we give? The recommended dose now 0.05 to 0.1 units per kg per hour. And how do you dilute? 40 units you take in 40 ml NS, so 1 ml per hour is 1 unit per hour. So that's how the dilution is made. So two things about insulin. One, never start insulin in the first hour. Two, never give a bolus dose of insulin. So why all this? What happens if you start insulin in the first hour of therapy? That is, you along with your IV fluids, if you start insulin, what happens? Or what if you give bolus dose of insulin? So again, go back to this your osmolality, cerebral edema osmolality. So what did we say about osmolality? We said we don't want the osmolality to fall very rapidly. You want it to fall very slowly. Okay, and what are the factors in osmolality? One is sodium, second one was glucose. So when you are giving fluid, okay, when you start with your fluid therapy itself, because there is when the dehydration gets corrected, the renal perfusion with your first bolus itself, the renal perfusion will improve. Okay, so when the renal perfusion improves itself, there will be loss of glucose in urine. So with that itself, your glucose will come down. Okay, so if you are adding, if you are giving insulin along with that, your glucose will come down very rapidly. And that can bring down your osmolality very rapidly, which we do not want. So that is why we don't want to start insulin in the first hour, nor do we want to give a bolus dose of insulin. Okay, so no boluses and no insulin in first hour. So this was a study we did in JIPMER in so this trial of low dose versus standard dose, that is 0.05 versus 0.1, and we found that low dose insulin, that is 0.05, is a safer approach because the complications, the rate or the time of resolution of decay was similar between the two groups, but the complications like hypokalemia, hypoglycemia were much lower with the low dose. So as a standard practice, we use only low dose insulin right now. Okay. Now, how about continuation? So that is how you start your fluid and insulin therapy. So how do you continue? Like we said, when the RBS falls to less than 250, you change the fluids to add dextrose to the fluid. Now, if the sugar is falling very rapidly, we expect a 50 to 100 milligram per deciliter per hour fall in the sugar. But if it is falling too rapidly, or if then the sugars fall, this is a BISPET guideline, okay? That is, if the sugar falls to below 108, then you increase the dextrose to 10 to 12.5. And if it's below 770, then give a bolus of dextrose and then increase the glucose concentration in the infusion. But as a personal practice for safety purposes, we generally try to keep the RBS around 100. And once the glucose RBS falls to below 150, we try to increase the dextrose concentration. So basically what you understand, as the sugars fall, we don't decrease the insulin rate. Why? Because insulin is important to correct the acidosis. Once you stop or decrease the insulin rate, your acidosis correction doesn't happen. Okay. So it is important for us to keep the insulin rate same, but to prevent hypoglycemia, what you can do is add dextrose to the fluid, increase the dextrose concentration in the fluid. So if you are doing everything right, but your acidosis doesn't seem to be getting corrected, then what do you think of? What should you do? So the first 3 points. The first point, as per my professor, he used to say, the first 3 points are insulin, insulin, insulin. Okay, so always double check, triple check your insulin. Make sure the line in which your insulin is going is patent. It may be bulging. Make sure it's a good line that you have put. You can change the infusion to another line, put another line. Or if none of this works, just discard this insulin, prepare a new one, and almost always that's what works for us. That is, always make sure that your staff has flushed the whole line, because otherwise insulin can bind to the plastic in the line and it will not work properly. So make sure that the line is flushed, and if nothing seems to be working, first thing you do is just change the insulin infusion. Okay. Then it could be that there is inadequate resuscitation. You have not given adequate resuscitation. Adequate fluids have not been given. Okay, then there is a fluid calculation error. If you're giving much less fluid than what is required. Okay, child is severely dehydrated and you're not correcting the dehydration adequately, then you may be having the acidosis may not get corrected. Then, as we discussed earlier, sepsis is one point where your acidosis may not get corrected. Then hyperchloremic acidosis. So this occurs when the child seems to be improving otherwise. Clinically, child seems to be improving, active, better appetite, better, neurologically better. But you see that your gases are not improving according to the clinical improvement that you see. So there you will look at the chloride. If you're giving NS or DNS for a long time, you can get hyperchloremia, and you will get a hyperchloremic acidosis, which is a normal anion gap acidosis. Okay, DK I said it's a high anion gap acidosis. So if your chloride is going up, you will get hyperchloremic acidosis, which may be the cause of persistent acidosis. Then if the child is developing AKI, that's another reason why your acidosis may not be getting corrected, or it may be very unusually some drugs. Now sodium and decay, sodium and corrected sodium. So what happens to sodium? Sodium, there is dilutional hyponatremia in decay. So what happens because of the hyperglycemia, there is rise in osmolality. And what happens when osmolality rises? There is water movement from the intracellular space into the extracellular space. Yes, water is drawn out from the cell into the plasma. So there will be dilution of the plasma. So you will get a low sodium level. So that is dilutional hyponatremia. Now, what is corrected sodium? Corrected sodium is the sodium which is expected in the absence of hyperglycemia. So if this child, let's say this child has a sodium of, child with 620 GRBS has a sodium of 132. Okay, what if this child had a normal GRBS, what would be the sodium? That is the corrected sodium. Okay. So what's the formula for corrected sodium? You have to add to the measured sodium 1.6 into RBS minus 100 by 100. That is, for every 100 rise in RBS, you have to multiply by 1.6 and add it to the measured sodium. So during treatment with insulin and hydration, the plasma glucose level is, the glucose concentration is reduced, right? So the hypoosmolality will be reduced. So now the water will start leaving the extracellular space and will go back into the intracellular space. So what will happen? This dilutional hyponatremia will get slowly corrected. So what are we expecting in the course of decay correction? You are expecting that your uncorrected sodium, that is your measured sodium, will go up slowly. That is what you're expecting with your correction of decay. Okay. So this is an example to calculate corrected sodium. Example RBS is 500, sodium is 135. So your corrected sodium is 135 plus 1.6 into 500 minus 100 by 100, which comes to, so this is 140 is this child's actual sodium. That is, if there was no dilutional hyponatremia, this is the sodium that you would get. Okay, so if your child has a corrected sodium of more than 150, you have to know that this child has severe dehydration, and so this child also has to be corrected very slowly. Now, the important point that everybody used to say till now was a falling sodium with the falling blood sugar. Again, come back to cerebral edema, osmolality. So we said osmolality is equal to 2 into sodium plus glucose by 80. So when the glucose goes to, and you want the osmolality to fall slowly. So when the glucose goes down, okay, if the sodium also goes down, what will happen? The osmolality will go down very rapidly, which we do not want. Okay, so a falling sodium with a falling glucose was considered, I would say was considered ominous, which it means that you are giving excess water, you're giving more free water. So there's an impending chance of cerebral edema. So you have to either increase the sodium content in your fluid, or that is, if you're giving half NS, you give it, change it to DNS, or you slow down the rate of the fluids. Okay. And your expected rise of sodium is, as the glucose falls by 18, the sodium is expected to rise by 0.5 to 1 millimole per liter. So right now, the current ISPAT guideline, that the 2022 guideline says that it is not very essential that the sodium should, the sodium should rise with the falling glucose. But definitely the sodium either should remain the same or it should rise. It should not fall. A falling sodium definitely is worrisome and has to be considered. So if you find that, you have to either reduce the fluid rate or you have to increase the sodium in the fluid. So that is why, in our monitoring chart, we have sodium as glucose and the effective osmolality. Okay, because we don't want the falling sodium. What about bicarb? It's always, when you see a pH of 6.8, it's always a tendency to just push a bicarb, but do not do that in decay, because the bicarbonate concentration is actually, see, what is bicarbonate concentration? It is the extracellular fluid bicarbonate content divided by the extracellular fluid volume. So the bicarb may be moderately reduced when there is both a large deficit of bicarbonate and severe contraction of the volume of the ECM. So the what happens, see, when I'm initially correcting this extracellular fluid volume, so you see this is the effective serum bicarbonate, plasma bicarbonate concentration is equal to the plasma bicarbonate content by the volume. Okay, so when I give a bolus initially, what will happen? This volume will expand. Okay, so what will happen to the bicarb concentration when the denominator increases? This will fall. So, you know, after your first bolus, it is possible that you get a fall in pH. Okay, because initially your pH may be 6.8 and your bicarb may be 3. After your first bolus, your pH may become 6.76 and your bicarb may become 2.2. So don't panic by that. That is an expected. It is possible because of the increased extracellular fluid volume. So anyway, the point is that you do not give bicarb because there is an increased risk of cerebral edema. So in DK, even if your pH is 6.8, please do not push bicarb. Okay. Only indication is a severe life-threatening hyperkalemia, which is very rare because we know DK is associated with potassium loss. So very severe hyperkalemia is the only indication. The other indication is severe acidosis with impaired myocardial contractility. But here again, you do not know if the acidosis is causing the impaired myocardial contractility. So be very reluctant in giving bicarb in a patient with DK. Again, hyperchloremia. So patient can develop hyperchloremia if you're giving continuously high chloride containing fluids like DNS or NS. So if the chloride seems to be rising too much, that is the chloride sodium gap of more than 0.79, then you can reduce the chloride level by changing to fluids like RL or plasmolite. Okay. Again, another important thing is phosphorus. So just like potassium, phosphorus also behaves in the same way. The phosphorus starts falling once you start insulin. So you treat it if the patient is symptomatic or the serum phosphate goes down to 1.5. So what you do is you generally start potassium as potassium chloride. Instead of that, 1/3 or 1/4 of your potassium replacement, you can start as potassium phosphate. Okay. And always remember, if you are giving phosphorus, always carefully monitor your calcium, because calcium can fall once you start phosphorus. So manifestations of hypophosphatemia, these are the clinical features, can have metabolic encephalopathy, impaired contractility, respiratory failure, muscle dysfunction, hemolysis, rhabdomyolysis, etc. Okay, so now we have covered the parts, that is the fluid, the electrolytes, the insulin. Now, what do you, when you are correcting DK, if you're going in the right track, what do you expect? One, RBS to fall by 50 to 100 milligram per hour. The pH should slowly rise. Bicarbonate should slowly rise. Uncorrected sodium should slowly go up. The effective osmolality should slowly decrease, and your your total counts, urea, hematocrit, potassium phosphate, all this will fall. Okay, so you have to, that's why we keep a close monitoring of this 2 hourly and correct as needed. So when do you say that DK is corrected? One, normalization of metabolic pH more than 7.3, bicarb more than 15, closure of anion gap. Why closure of anion gap is important? Because like we said, if there are other causes of the acidosis, like if there is a AK, there is a hyperchloremia, I'm sorry, if there is hyperchloremia, the acidosis will still persist. So the pH will still be less than 7.3. Okay. But if you look at the anion gap, if the ketones are gone, then your anion gap should be normal. If it is just a hyperchloremic metabolic acidosis, your anion gap will be normal. So if there is a normal anion gap, then you can assume that the DK is corrected. Then reversion of normal sensorium and BOH less than 1. So sometimes the BOH again is useful in this scenario when your pH and all may be still low because of your hyperchloremic metabolic acidosis. And again, once more reiterating that urine ketone is not used for diagnosing the resolution. Okay. Then when do you transition to subcutaneous insulin? So when you have attained resolution, you transition, and usually by then child is ready to take orally. Most convenient time is just before meals, and so you give subcutaneous insulin, and after half an hour you start, or an hour later you stop the insulin infusion to prevent rebound of hyperglycemia. And how do you dose the subcutaneous insulin? If you are a new patient, we generally start at 1 unit per kg per day, divided doses, or you calculate the total insulin required for the correction and divide it. And this is just the rule of thumb. Okay. Just a few words about cerebral edema. I'm not going to the pathology and all that. So, risk factors: if the child has severe hypocapnia, that is very low PCO2 at presentation, very high urea at presentation, very severe acidosis at presentation. If bicarb is given, then very rapid decrease in effective osmolality, or attenuated, that the sodium is not rising adequately, or that there is a sodium falling, or if the large volumes of fluid are given in the first 4 hours, if you are giving insulin in the first hour, all these are risk factors for developing cerebral edema. So if a patient comes in severe acidosis, has severe low CO2s, high ureas, always be on the lookout for cerebral edema. That's why we monitor GCS hourly or even more frequently. Okay. So what are the symptoms? I don't have to tell you that. It is headache, agitation, irritability, altered sensorium, unexpected fall in heart rate, increased BP. Okay. So they are all very subtle symptoms and signs. So always be on the lookout for that. For any level of deterioration in consciousness or abnormal breathing patterns or any oculomotor palsies, pupillary inequalities, abnormal posturings, etc. How do you treat? Immediately you have to give either mannitol or 3% saline, and then head and elevation midline position. Reduce the fluid, okay? Reduce the fluid to 1/3 or half of what you're giving. And once the child is stabilized and if your altered sensorium still persists, then you may have to do imaging to rule out other causes. So what are the more important causes of mortality and morbidity in DK? Most important cause would be cerebral edema. Others are hypokalemia, so the electrolytes. So that's why it's important that we track them very diligently. Hypoglycemia, so increase your dextrose concentrations as the glucose starts falling. Then your CNS complications, embolisms, it's a prothrombotic state, so thromboembolisms, then sepsis, pulmonary edema, rhabdomyolysis, AKI. This is the last and very important slide. Sick day management. Okay, so DK, sick day management very important. More than correction, you want to prevent DK. So if the child comes, child with diabetes becomes sick, tell them never to stop insulin. Check the blood sugars more frequently. If the child comes to check for the blood glucose, if child may require more fast-acting insulin more frequently. Keep the child well hydrated. Okay, so coming to the take-home messages. I first put the sick day management because we don't want, prevention is better than cure. So sick day management, any child has to be taught even before the child, when the child is getting discharged. Then another important thing is if a child comes to your clinic or your ER, child is lethargic, child is sick, you don't feel anything, other examination doesn't yield much. Definitely don't forget to do a GRBS. It may be a DK, may not have, okay, an early DK, which may not have evident, evident presentations. So always in a sick child or a child who's not looking very well, please do an RBS. No bicarbonate, no bolus insulin, no insulin in the first hour. This is absolute no. And meticulous monitoring. So we want a slow rise of sodium with the fall in RBS, and we want the effective osmolality to slowly fall with the correction, as the correction goes. So I think I'll end my presentation with that. Thank you for your patience.
Thank you, Dr. Shilpa, for a very lucid presentation. I'm sure the pearls of wisdom were falling so rapidly that people were not able to gather them all. I wish many of our audience had come prepared for this talk, because Shilpa has covered every aspect of managing DKA so beautifully, and particularly pointing out every detailed step that we have to look after. Because if we do not manage DKA optimally, we can really burn our fingers. Unfortunately, we see that often many of our even mild DKA patients receive bicarbonate in several places. So watching out for cerebral edema, looking at the potassium, not to start insulin immediately, all these are very valuable points, and all these need to be mulled over several times before we can actually optimally manage a child with diabetic ketoacidosis. We seem to have received a few questions in the chat box. but only appreciation for an awesome class. So just to complete, may I ask a silly question? Do you often come across hyperchloremic metabolic acidosis while managing DKA, Shilpa?
Yes, I mean, it's quite common. I think because we generally don't use half NS. We mostly we continue with the DNS. So that is probably one of the reasons why we quite often see hyperchloremic metabolic acidosis. So it's quite often seen, especially if you use, if you continue to
Normal
use,
saline.
yes, DNS.
So thank you so much, Dr. Shilpa. Once again, even this was education session for me also, particularly all the changes in the guidelines that you mentioned. Thank you so much. Now I hand over to Dr. Leena for the concluding remarks.
Thank you so much, Dr. Anleka. I would like to thank our speaker, Dr. Shilpa, for that extensive and informative talk on DKA. I also thank our moderator, Dr. Anleka, for the discussions. Above all, I wholeheartedly would like to thank all the participants for being a part of this session, and I'm sure all of you really enjoyed the talk. Before closing the session, I would like to invite you to the next webinar. I'll just... Yeah. Can you see the slide, Dr. Anleka?
Not yet.
Okay. Is it seen now?
No.
Dr. Shilpa, are you still sharing the screen?
Oh,
No.
I stopped.
Can you just stop it?
Yeah, I stopped.
I just... yeah. So... yeah, you can see it now, right?
Yes, yes.
So this is our next webinar. So I, along with Believers Webinar and Clinics Committee, would like to invite you all to the next webinar, which is our 87th webinar, which is Challenges in Anesthesia During Bariatric Surgery. It is presented by Dr. Ashu Saramatai, our professor and HOD, Department of Anesthesia. So thank you all once again.
Thank you. Thank you so much.